I'm going to present you a cataract surgery and IOL implantation in an extremely short eye. Eyes at the extremes of axial length be challenging to operate on. Cataract surgery in non-ophthalmic eyes is associated with significant risks and complications and often require the use of IOLs with refractive power above 40 diopters. Previously, options included implanting foldable IOLs with the highest refractive power available while leaving patients hyperopic. High-power PMMA IOLs require large incisions or piggyback IOLs, although each has its own set of complications. A foldable one-piece high refractive power IOL provided significant improvement in the refractive errors and uncorrected visual acuity while avoiding complications that may occur with a large incision or piggyback IOLs in these small eyes. Lens removal in this patient population had been proposed as a treatment option through the relief of anterior chamber crowding. Historically, lens surgeries in the extremes of axial length and non-ophthalmic eyes have been associated with high levels of complications, including posterior capsule rupture, malignant glaucoma, choroidal hemorrhage, uveal effusion, vitreous hemorrhage, and retinal detachment. Lens surgeries in non-ophthalmic eyes appear to be safer with recent improvements in phacoemulsification and intraocular lens implantation. Comparatively, a single-piece, high-power foldable IOL implanted in the capsular bag has the potential to neutralize the refractive error in these eyes and to address some of the concerns with the aforementioned options. Of note, zonular weakness appeared to be an intraoperative finding. For this reason, the use of single high refractive power IOL may provide a potential advantage over piggyback IOLs, as multiple IOLs in the crowded anterior segments may induce excessive tension on the already weak zonular fibers. The VSY Extreme Diopter 613 UD IOL is a customizable single-piece 13 mm C-loop foldable monofocal aspheric IOL with refractive powers between 45 to 60 diopters. The IOL used has a diffractive optic profile. Because of this design, the IOL features a standard central thickness of 1.25 millimeters, even for extremely high diopters. Thus far, there has been no publication on the safety and effectiveness of this lens to correct the large refractive error and improve visual acuity in non-ophthalmic eyes. This case provides our initial experience with this IOL and in non-ophthalmic eyes undergoing phacoemulsification. The IOL comes in a sterile glass container and is to be used with a Viscojet 2.2 cartridge and injector set. The IOL can be inserted through an incision size of 2.2 millimeters and is designed to be placed in the capsular bag. The IOL calculations were made using manufacturer's proprietary safe software. Phacoemulsification was used and any additional adjunctive procedures were performed at the surgeon's discretion. Our patient had a preoperative refraction of 15.50 diopters in the right and 15 diopters in the left eye. Anterior chamber volumes were 198 millimeter cubes in right and left eyes. Anterior chamber depths were 2.46 and 2.59 in the right and left eyes respectively. Axial lengths were 1652 and 1670 again in the right and in the left eyes. Corneal diameter was 11.17 in the right and 11.20 millimeters in the left eye. Planned IOL powers were 54, 52 diopters. Postoperatively, our patient reported dysphotopsia, describing concentric circles around light sources. Overall, the patient was satisfied with the final visual outcome, and his final refraction was 1.75 in the right and 0.75 in the left eyes, with a very negligible amount of astigmatism. Thank you.